everyone. I see we have many people on the call from all over the province. I'm Andrew Kessler. I'm an emergency physician at St. Paul's Hospital and elsewhere, also in the Providence Healthcare and Vancouver Coastal Health System here in the Lower Mainland. This is actually the first webinar of a series to cover the basics of emergency department opioid use disorder care. And today we're sharing some core nuggets for you about the real bare minimum essentials. We're very lucky to have many different kind of panelists from different kinds of backgrounds on this webinar today. We have Elder Doris Fox joining us. She's a Musqueam elder. We have Paula Tate, an educator from FNHA, myself, my colleague, Dr. Isabel Miles, who's an addiction specialist and emergency physician at Providence Health. We have Raya Roberts, who's a peer advocate and the vice president of BC-APOM. We have Nicole Fairbairn, who's our support person from the BCCSU and helping us with all kinds of logistical issues. And again, our representative from the BCCSU, which is supporting this webinar. And then we also have our colleague, Dr. Melissa Allen from Fraser Health, who's been on the organizing committee. So again, thanks everyone for joining. Isabel, I think you have a few more things to share here.
Okay, thanks, Andy, for setting the stage. A bit more on the intent of this webinar. So we really hope that this is going to be interactive, some good case discussions, but be mindful if you're not speaking to keep that mic muted. If you have any questions or want to comment throughout the webinar, especially as we're asking questions with individual cases, you can either contribute by doing the raise hand function or reaction so we can see that you want to speak, or don't be afraid to put it in the chat. There'll be a few of us monitoring it throughout the presentation. So to first start off this wonderful webinar, we have the privilege of having Elder Doris to give us, from the Musqueam Nation, to give us the welcoming prayer to really set the foundation for this webinar and series. Off to you, Elder Doris.
Thanks, Nicole. Good to see you. Oh, wow. Mi tzavgod kuilam, itzent Musqueam, and the Doris Fox, I swile. Welcome everyone to the traditional unceded ancestral territory of the Musqueam people. We raise our hands in gratitude to you for coming in a spirit of love, honor, friendship, and respect. We ask that you keep an open heart and an open mind, excuse me, so that you can get the most from this evening. My great-grandfather Manette always said, knowledge is ours to share. It's not ours to keep. So we thank you for sharing some of your very valuable time with us in order that we can learn from each other. So I raise my hands in gratitude to you for coming this evening. Thank you so much. Thank you.
Okay, thank you so much, Elder Fox. I think our Isabel, you had a couple points you wanted to make before we got started.
Yes, again, thank you, Elder Doris, for such a great foundational setting for our webinar. A few disclaimers. These cases are based on real clinical scenarios that many of you have submitted to us, but we have adapted them a little bit for simplicity. So if they don't look all too or exactly familiar to you, that's why. The aim for these quick hits is that they're really going to be based on the simplest case outcome. We realize that most care is actually more nuanced and complex when you're doing it out in the community. So know that we have future webinars planned for that in the future to address it. And then next, Andy. And we also recognize that this particular field is ever changing in response to the ongoing opioid crisis. We try our best to highlight some of the BCCSU guidelines, but we know that there's innovative approaches that we want to discuss, but we'll be really explicit when that happens. We'll try to answer as many of your questions throughout also the webinar, but there may not be time during the cases. There'll be time at the end, and whatever questions we don't answer, we'll be sure to highlight them in future webinars or answer in a roundup email after this webinar is complete. Off to you, Andy.
Great. So here's our program for this evening. We've had the welcoming prayer from Elder Fox. We have 5 cases, and we'll spend 10 minutes or less on each of them. Time to go over some basic learning points and for you to ask questions or share experiences as we go. And then we'll have a few closing remarks and Q&A at the end if there's time for it. There'll be a closing prayer from Elder Fox. And again, for anybody who wants to stay late afterwards for any questions we haven't got to, we are happy to stay 15 minutes or so after the end of the webinar. And we will also address any remaining questions via email if we don't even get to those at the end. So with that, I'd like to go ahead and start with our first case. And this is trying to come up with a simpler approach or a basic approach to making the diagnosis of opioid use disorder. And we'll start with a case. So our case is a 24-year-old male who's brought to your emergency department by ambulance after an overdose. It was an opioid overdose. It was reversed with naloxone. You do a quick chart review on him and you find out that all his prior emergency department visits seem to have been linked to stimulant use, and he's had psychotic episodes with those. He's got not one single prior visit seemed related to opioids. You look at PharmaNet, he doesn't have any medications. And so the question before us and for all of you is, does this person have opioid use disorder? What do you guys think? So feel free to chime in or put something in the chat.
I'd say there's not enough history to support it at this point.
Yeah, so I struggle with these cases also, and so I maybe, Isabel, what would you suggest as things to sort of pin it down? I mean, I guess, we can ask him how frequently he uses. Is he using every day? Does he ever experience withdrawal? Has he ever been on treatment? Those are a few things that pop into my mind that I might ask, but I don't know if other people have questions or an approach, or if Isabel, you want to sort of fill in some of the blanks for us.
I think it's something that's great that's highlighted is that a single overdose doesn't necessarily equate, or single use perhaps of opioid doesn't necessarily equate a diagnosis of opioid use disorder. So that pause is really great. And then a great question from a great other thing that was brought in from the chat from Sophie is that, did you really intend to use those opioids? Was it an intentional overdose or was it contamination? So Andy, do you want to go to the next slide, maybe perhaps?
Yeah, so go ahead.
So what are some other questions or sources that could help you? And some of those questions you've greatly highlighted is like, okay, what is their use pattern? Do they even use opioids? It's a simple question as that. And have they come in for other visits? Is there any other medications on PharmaNet? Are there other things or places or questions that people tend to like, or high yield questions that people like to use that really helps pin down a diagnosis of opioid use disorder?
So I have a question for Raya here. So I know, I think sometimes we have a strong feeling based on the patient's presentation that the person may use opioids, and sometimes people say, F off, or, don't want to talk about their substance use. What do you, or at least not initially, do you have any suggestions for the group of how to kind of approach that issue or potentially make somebody comfortable sharing their substance use, or knowing also when to just let it be?
Yeah, I think that is a tricky one, because I think we have to assume that you know, we don't know this person and they don't know us, and starting from a place of, okay, who am I? I'm a physician, or I'm a nurse, triage nurse, and so I have, you know, I have more power than this person coming in with the overdose, certainly, and especially if they're you know, if they're unconscious, but you know, but when they are conscious, I would say being there's no right way to ask a question like that, because it sort of depends on the interaction and the energy between the energy of the person, and how they're feeling, and you can sort of feel out what ways you would ask a question like that. So one size doesn't really fit all. There's not really a one question that you can ask if they have an opiate use disorder, if they've used opiates in the past. A lot of patients are really reluctant to tell physicians that they've used drugs. They might say, oh, I've only used stimulants once, you know, but you can see that maybe they've been in the emerge before. And so I would be really gentle about that, right? And I would just make sure that they know that I'm a safe person to disclose this to, and that I'm not here to judge them, and I'm here to help them. And what do they need, right? That's always the question that I think I always feel is missing, is like when the patient wakes up, you know, what do you need? Rather than launching into like, okay, so have you used opioids before? How many times have you used opioids? What's your history? When did you start using marijuana? Blah, blah, blah. What do you need? How are you feeling, right? Starting there, and then that's gonna probably lead you somewhere.
That's great, Raya. I really appreciate that. And I think just that, not necessarily just going through this kind of that list of questions that we may sort of be dying to know the answer to from a medical point of view, but that may not be the questions for the patient at that time.
Let's slow down, because the patient is just probably, they're probably still confused, and you know, and so they're not we need to be slow. We need to slow down. We need to be gentle. We need to meet them where they're at. Yeah.
Absolutely. Thanks for that. My next question is a bit you know, directed to Isabel and to the group, if you've come up with some good shortcuts. But you know, I think, you know, I sort of know in the back of my mind that I need the DSM-5 to confirm opiate use disorder, but I know it's a sort of a long string of questions, and it's a bit daunting, and my appetite to kind of go through all that is not huge. I suspect, as Raya kind of pointed out, the patient's appetite to go through all that may not be so high either. So what is there kind of any shortcuts we can take, or how can we kind of be rigorous but not overdo it?
While people are taking times to craft their answer, I think it's just to kind of bring it back to what Sophie said, is to say an overdose is a trigger to ask more questions, but does not equate necessarily opioid use or OUD. So kind of reviewing things. And then what Raya said is then asking permission to the patient to ask these questions and explaining to them what you're doing. And then what Jason highlighted is that there's probably a few key things in the emergency department that you can highlight to really settle down on a diagnosis of opioid use disorder. And the biggest thing is, have they experienced withdrawal, right? That's at least a couple criteria in terms of physiologic change. You've set the bar. And now you only need maybe one or two more to reach this threshold for opioid use disorder, which is a minimum of 2 criteria. So asking them if they've had consequences around their use, have they come in for infections before? Do they crave using that particular substance? And explaining to them why you're asking these questions. You don't need to go through all 11, you've got 2. And if your intervention is to provide, you know, safer use or just buprenorphine, that's really all you need. There are certainly certain cases where you want to pause, and if you're not sure, to go through those criteria. But with those three, I think you've certainly done the bulk of the work without having to go through, the tedious task of the DSM-5 criteria. Does anybody else have a good key question to ask?
I think maybe then we can sort of kind of whittle it down based on what we've talked about. What do you think are the, well, I guess that one last question is just, we may not screen everybody for opioid use in the emergency department. We may not have time to, but are there some high yield patients we should be sort of keeping in mind? And then and then I think we should just sort of get down to sort of the nuggets of this case.
Mm-hmm. Yeah, Andy, why don't you move on to the next slide and we can answer some of those questions. So, what is the nugget of this case? I think to highlight is that diagnosing somebody for with opioid use disorder can feel daunting, but be mindful that it does stick. The diagnosis of OUD does tend to stick to a patient's chart, and it does determine the benefit of prescribing something like buprenorphine, naloxone. Being mindful that opioid use should be a trigger to screen, including overdoses, but it does not equate a diagnosis of opioid use disorder. Other key presentations that should really just have that mental model connected in terms of further screening or asking further questions include recurrent presentation for cellulitis, abscesses, and of course, overdoses, which we've said time and time again. You always want to confirm that diagnosis by going through the DSM-5 criteria, but use those shortcuts, right? The things that have been highlighted by Melissa in the chat or by Jason in the chat. You only need 2 to pass that threshold. So ask about withdrawal, or if they're presenting in withdrawal, do they experience cravings? Have they had consequences related to their opioid use? And then when in doubt, go through the full criteria. That can feel daunting, but know who you can refer to who can maybe clarify that further for you. All right. Any questions based on simplifying diagnosis of opioid use disorder? I'll pass it back to you, Andy, for the next case.
Okay. So our next case is about withdrawal management. This is a woman who presents the emergency department. She's got severe nausea, vomiting, abdominal pain, which she feels it's because she's in opioid withdrawal. She says she feels dope sick. And you do an exam on her, and she's actually quite tender in the right lower quadrant, and you're suspecting appendicitis. You'd like to do some imaging for her. And the patient is very uncomfortable, and she says that she would like to leave so that she can use opioids and take care of her withdrawal. Has anybody ever faced a similar situation, and what do you do in these kinds of cases?
Hi, I'm Brianne. I don't know if you guys can hear me or not. I'm an ER nurse, and we unfortunately deal with this quite often, where there's something bigger going on than what is actually, than just an opioid withdrawal. And then we're worried if they leave, they're actually going to get sicker and not have the help they need. So I just usually ask flat out, what do you need? What would you use if you were out to treat yourself, and how can I match that? And so I know a lot of nurses are hesitant because they don't, I've come across the nurses that feel that they're just kind of feeding into it. But in my view, I don't really care. I want to do what's safe for them. So if it means I need to give them a ton of Dilaudid to get them through that moment so I can properly assess and do the scanning that we need to do, or what is it that they need? So I just usually ask them flat out, what would you like? What do you need? And what can I do for you?
Mm-hmm. Yeah, that's a great point to really get the patient into that discussion and sort of really dictate what they need. Maybe a question for you, Raya, also. I mean, besides just medications, kind of what else is kind of key to kind of getting the patient on board or feeling like it's a team effort and supporting this patient through this difficult experience, and convincing her to stay, like besides just opioids, which it sounds like will definitely help. What else should we be thinking about?
I mean, I think like opioid being in withdrawal, and certainly stages of withdrawal where you have abdominal pains and vomiting, maybe is a later stage of withdrawal, and so that's quite serious, right? And so letting the patient know that the withdrawal, if they are in withdrawal, they may be in withdrawal and have an appendicitis. And if they are in withdrawal, that's a big deal, and you do take it seriously, and you do know that it's serious for them. It's life or death for them, really. It's quite uncomfortable, and they can't necessarily stay if they're in withdrawal, and the withdrawal isn't being managed. So I would say just making sure that they know, that their pain, their discomfort is important, and you care about it, and what can you get them, and that you want them to stay, right? I think the previous response was fabulous, right? Treating the withdrawal so that they can stay, because you want them to stay, because you want to treat their appendicitis if they have that, right? But also, they are free to leave. And if they do leave, just making sure they know that they're welcome to come back, right? We want to help you.
Mm-hmm.
I just would like to kind of build upon that, if that's okay, Andy. I think it's a great thing that's highlighted. I'm sorry, I missed your name, but it was so great in terms of asking where the patient's at. And it was interesting comment to say, well, are we feeding into the addiction? No, opioid withdrawal is an emergency, right? So you have to treat it with appropriate interventions. And if anything, you're providing safety to the patient, because we know undertreated withdrawal increases rates of leaving, but you're also maintaining that patient's tolerance, which is important in terms of mitigating risks of overdose when they're leaving hospital. I just wanted to put it out to the group in terms of like, how do you determine that the dose? Like, what do you determine, or how do you decide how much the patient might need?
Peter has his hand up. You can go ahead, Peter.
So I think you just have to be matter of fact with these patients, and all the things that we've said so far. It's pretty common to see both things happening at once. And of course, if they do have an appendicitis, they have a high opioid tolerance, they're going to need a lot for pain, and we want to make sure that pain is controlled. So acknowledging that, tell them, hey, we're going to treat you as best as we can. Just ask them, like, how much are you using? Like, when was the last time you used? And like, are you using heroin? Are you using something else? How many points are you using here? And just kind of dose appropriately, and just tell them that we're going to make sure you've got plenty of opioids available for you if you need. But if you feel we're not meeting your needs, please let us know, or let me know, and I'll come and attend to it personally to see if we can do a little better with it. And then just continue your workup as you would otherwise. You're really just treating two things at the same time. And I think just being open and honest and non-judgmental with it is going to get you as far as you need to go with them.
Can I just also add, Peter? Yeah, I think that's brilliant. And I would say that patients maybe have a tendency to underestimate the amount that they use when they're talking to a doctor. And so they might say, oh, I use maybe half a point a day, when it's 1 point or 2 points a day, right? So just remembering that is something that can happen that is something that happens. And so making sure to check on them again, how's your pain level? We're here to treat your pain. We want to treat your pain. We're not just going to give you 2 to 6 milligrams of Dilaudid every 2 hours. That's not all we can do for you. We can do more for you, right? And just making sure they're comfortable as well in the environment, right? Do they need to lay down? I think that's something that I was going to mention before.
I think it's safe to go big with these folks too. You have them in your ED and they're monitored. So, you know, if I get the sense they're really pushing into withdrawal, 8 milligrams every 30 minutes of hydromorph, I'm not afraid of doing that. And you just kind of see where you go from there.
Yeah, no, that's it. Those are great
oh,
points. Oh yeah, go ahead.
Charles just has something in the chat that I'm sure, I suspect a lot of people are thinking, because I think this often also, just about like what people say about a point and stuff. We can maybe address it now or after, and we don't know. And yeah, from my experience, like it takes such teamwork between the nurses and the physicians for patients like this, because as a physician, I write the initial order and I know I underdose. Because I'm not used to the big numbers. Like I'm not used to the opioid tolerance, and then I leave and go to a different zone, and I really count on the nurses to feel comfortable telling me if the patients are telling them or showing them signs that they're not in withdrawal. So it's something to talk as a team about how you're going to manage these patients also.
Yeah,
I don't know if other people. But
that's a great point about sort of that. It's sort of often a sort of a three-way situation between nurses and the physician and the patient, and trying to make everybody work together. Just with that in mind, I know, Isabel, you have some nuggets for us, and maybe you'll touch on at that stage on some sort of specific recommendations of sort of, you know, what might be a reasonable starting point. You know, if we really have sort of no idea what a point is, or like Raya said, they may be underestimating their use. And so what would be a safe place to start?
Thanks, Andy. So I think what's kind of been pivotally emphasized here is let the patient guide you, let the patient be part of the team effort to really address their needs. And that could include your nursing staff, your pharmacist, your peer, whomever you can, to really make sure that they're supported in the emergency department. Medications and environment play an equal part. I think this will be highlighted later on, but always just keep in the back of your mind to assess the possibility, could this person be a buprenorphine naloxone candidate? Obviously, an acute medical illness is a contraindication, but you still want to go through that exercise first. It's probably the best medication to really treat withdrawal long-term, if they're interested. If they decline or their contraindication, like I said, order those immediate release opioids early. Don't wait till they're in withdrawal. Order them at the outset of the visit, so they're there and waiting for the patient. And then on discharge, if their plan at that time isn't buprenorphine naloxone to treat their withdrawal, still provide them with the tools when they leave hospital to explore other options to stay safe and out of withdrawal. So to the nuts and bolts, how do you order it? Well, about a point is about 1/10 of a gram. That cannot necessarily mean an exact amount of fentanyl or down. And be mindful that a person's reported use can be underestimated, overestimated, but also really changed by how sick they are. So you can't really estimate based on how much they're using outside a hospital. So that's where guiding the patient, both you and them, is really important. I generally start with morphine oral liquid, either or tabs if that's available, 20 to 30 milligrams every 2 hours as needed. Consider ordering your first dose right away so that the nurse isn't waiting for the patient to ask, but also remind your patient to ask for those doses. You want to wait every 2 hours because, again, any oral opioids peak after an hour and a half. You're not going to see the full effect until that time. Indicate that it's for withdrawal, pain, and cravings, because that often leads to leaving. Order oral hydromorphone if they're in renal impairment or if that's what you're comfortable with. 4 to 6 milligrams is the equivalent 1-to-5 ratio. Reassess your patient frequently and consider increasing your dose 30 to 40 milligrams if that's insufficient. And let your patient know that that's what you're doing, that you're recognizing you're underdosing, but you're making sure they're safe. All right, Andy, back to you.
Okay, thanks for those tips. So our next case will be on starting buprenorphine naloxone, and it's actually the same patient we saw in the earlier visit. So in the earlier visit, fortunately, her CT was negative, and she felt better that her withdrawal was treated appropriately. Then sort of before discharge planning, she did leave. So there wasn't any sort of concrete plan in place. but she does come back 2 days later in severe withdrawal, and she thought she could manage the withdrawal in sort of going cold turkey, but it really hasn't gone well for her. And she's now interested in starting the medication you mentioned the last visit, the buprenorphine naloxone, and she hasn't used any fentanyl in the last 24 hours. So how should we approach this one? Like, is this person a good candidate for Suboxone? Is it just because she says she's willing? Should we just go, or what are the things we need to look at? So I think we all know there's some sort of time parameters, and I guess it's always been a bit of mystery to me about fentanyl and why it's waiting 24 hours, and when I think we were all taught initially it was a sort of a fast-acting opioid. So I don't know if you can sort of explain the waiting period around fentanyl, and then maybe we can talk about the cows and other things we should be looking at.
So I'm assuming you mean myself, or if anybody else is interested in answering this question, but maybe I'll take the lead. I think your first question is great. Like, is this person a good buprenorphine naloxone candidate? Yeah, they wanna start, right? So that's kind of the most important thing. They're ready and they understand, and they're at that stage, and they're they're ready. So that's kind of the main important thing. Now, the next thing you're asking essentially is what are we trying to avoid? Like, we're trying to set up then the best scenario for this patient to succeed, and that's trying to avoid precipitated withdrawal. So then putting it out to the group, traditionally, what have we been taught in terms of time since last immediate release opioid use can we start buprenorphine naloxone? Victor says, thankfully, we have an order set to remind ourselves. That's great. Yeah, those are certainly things to just simplify the approach and remind ourselves and make it a little bit less onerous and daunting on a busy shift. So what's the time? Anyone can throw it in the chat. Just put some random times between anything between 8 to like 72 hours. 12. Yeah, so traditionally it's been between probably 6 to 12 hours that we've said for things like heroin, hydromorphone, or morphine. However, fentanyl is a bit of a funny beast. So it acts really quickly on and off, but in people who consume daily, it actually is quite lipophilic. What that means is that it builds up in the system and it takes a little longer to clear. So what we've noticed in community, or at least in kind of practice, is that you have to wait a little longer for that buffer of enough mu receptors that are empty, so that when you give buprenorphine, people feel better and not worse. And that's been generally a minimum of 24 hours. I don't know what you've seen, Andy, or if anybody else has seen anything differently.
I think that's a good point. And I think also just making sure that, asking the person about their opioid or history with OAT. I can't remember if this person is not on OAT or have they ever been on OAT? Maybe they have, maybe it was 20 years ago, but maybe it was like 6 months ago. Maybe it was a month ago. Maybe they've been on a series of different, they've been on and off methadone, and that's really going to potentially impact the transition to buprenorphine and whether or not buprenorphine is really appropriate for them.
Yeah, that's a great point, and that's again the sort of the human and experiential element of what's going to sort of be affecting this this patient. And I guess going back to so that's the human element, and thanks again just for flagging that is so important. And then sort of going back to the physiology for a minute, then how, we know, I think that the cows has to be greater than 12. We want to see signs of moderate to severe withdrawals. But I know there's some potential pitfalls there. And I think we still hear stories occasionally of people going into precipitated withdrawal, even when they've been scored at a COWS of 14. So how can we avoid that?
Okay, so I think there's again a couple of questions to highlight. We probably need a bit more time. People have experienced precipitated withdrawal at 12 hours. Again, it's because fentanyl sticks around for a bit longer. So you need longer for it to kind of drift out of the receptors. With that, you just need to really be sure that the COWS is actually reflective of a moderate withdrawal. So again, enough empty receptors to feel better when you give buprenorphine rather than feel worse. The key things is that you're asking the patient a lot of questions. So with any kind of withdrawal scale or monitoring scale, there are limitations and there's a lot of variability. So part of that is that you want a larger proportion of your withdrawal scale to be objective signs, so things that you're looking at. It's very important to engage with the patient to ask how they're feeling, but you want to make sure a large proportion is objective. So let's say at least 2/3. And a lot of us, again, this is outside of guidelines, in clinical practice are actually looking for a higher threshold of 16 to 18 because of those experiences with precipitated withdrawal with longer periods of use without use. I think the other important thing to highlight as well is that you really want 24 hours without use. So even if they use just a little bit, that resets the clock. So you really need to give that time.
Thanks, Isabel. And I guess the next piece is sort of, let's say they're ready to start, all the numbers are right, the waiting time, the COWS score, the objective elements, and where should we start? And I know we have a specific guidelines in BC that say starting at 2 milligrams. I know there are other guidelines in the States that start at higher. So what should we do? And are there times we can maybe increase a little bit beyond the sort of initial 2 milligrams?
Yeah, so generally for the same reasons, because of the concern around the higher risk or less buffer for precipitated withdrawal with fentanyl, we want to start at 2 milligrams. A precipitated withdrawal 2 milligrams is much shorter in duration and much less severe than, say, for example, at 4 to 8. So it gives you a little bit more buffer for reassessment and catching it early. Once you reach a threshold of 3 to 4 doses, so assuming you do the 2 milligrams, then you're at a safe enough kind of overall amount of buprenorphine that the likelihood of precipitated withdrawal is much lower. So if the patient's still in severe withdrawal, then you can start giving larger doses of 4 milligrams.
That's great. And then what about, how do we know when things are not going well? Like if we're going to see precipitated withdrawal, when are we going to see that?
That's why it's so important to reassess your patient frequently. And generally, you're going to see worsening signs. So oftentimes objective signs come up sooner, dilated pupils, feeling a little bit more agitated, restless, and pilorection within 15 to 30 minutes. If the withdrawal gets worse, greater than an hour or two, it's likely you're underdosing the Suboxone. So again, that time of onset is after dose is so important to distinguish.
Great. And we've talked about the large doses, and then just keeping track of time here so we get to the remainder of the things we have to talk about. Maybe you can just give us some nuggets around, how do we know when we're done, and what else do we need to know about buprenorphine?
Okay, thanks, Sandy. So like any procedure, the setup is the most important thing for success. So the key to success for a great and smooth buprenorphine induction is avoiding precipitated withdrawal. So there's a couple of key things to make it easier for you. identify the right patient. So time since last use of fentanyl, you want at least a minimum of 24 hours. As Raya said, you want to engage with the patient to say, are they actually on anything else that might kind of alter your timelines as well. So asking about the patient's experiences. You want to look for signs. So you want a COWS of at least 13, but actually consider a bit higher if they're consuming fentanyl daily. Use a calculator or an app to make it much easier for those calculations. You want a good proportion of your signs to be objective, again, for a little bit more of that buffer. Make sure you have verbal informed consent with the patient. There is a possibility, regardless of what you do, that precipitated withdrawal might happen. You'll be there with them and have a game plan before. And make sure you reassess the patient frequently so you can address and catch that happening earlier on. For logistics, we already talked about dosing. The other important thing in a busy ED, make sure that the patient's taking it properly underneath their tongue and they're not swallowing it. Once you reach that threshold of 3 to 4 doses, so 6 to 8 milligrams, then you can go a bit quicker because your risk of precipitated withdrawal, it's much lower. Again, if you're thinking of precipitated withdrawal, that onset of worsening withdrawal symptoms should really be between 15 to 30 minutes. So onset, not peak, after dose. If it's beyond that, it's probably you need to be a bit more aggressive with your buprenorphine naloxone. And then for your final amount, you want to aim between 12 to 16 milligrams to maximum of day 1 or symptom resolution. And then the most important thing is that you've done such a great job starting somebody on buprenorphine naloxone. You've got to make sure that they can continue this life-saving treatment outside a community with a bridging script, meds to go, or at least next day follow-up, and make sure that they're connected with supports in the community so that they continue that successful start that they've done along with you in the emergency department. And I see that there's a couple interesting questions around microinductions and different ways to start Suboxone. And certainly that's a time where we're going to be exploring those more nuanced cases in our future webinar at the end of November. Back to you, Andy.
Thanks, Isabel. Another scenario we wanted to talk about, because it does seem to come up often in emergency departments, both in my own experience and from speaking to colleagues around the province, is how to deal with a dose of missed OUD, and specifically methadone, because it's probably the one that most people are on in BC, and how should we approach this type of cases. So this patient is a 23-year-old male. He has a known history of opioid use disorder. He's on methadone, 140 a day. He's there in your emergency department today because he's had some suicidal thoughts, and he's waiting for assessment by psychiatry. So he's going to be in your emergency department for some time. You know, it's the end of the day. He's not going to make it to the pharmacy that day to get his dose. He's missed 2 doses already, and he says he's now starting to feel like he's getting to be in withdrawal. So he's requesting his dose. And so, you know, should we just give it to him, or what are the things that, you know, will kind of help us decide if it's the right thing to do to give him his dose, or maybe, you know, choose a sort of an alternate plan to address his symptoms?
I guess the first question is, does this case resonate with a lot of people? Certainly, that's a question I've heard really commonly, and it can feel a bit overwhelming on how to approach it.
I would say that, you know, certainly it's very easy to look up on Pharmanet whether or not they have indeed missed 2 doses of their methadone. And if a patient has missed 2 doses of methadone, especially if they've been on methadone for a while, they're probably in quite severe withdrawal. And so they probably need, I mean, I would advocate for a dose of methadone and a bridge script or some sort of referral to where he can go next.
Mm-hmm. Yeah, and I think, thanks, Ryan. We definitely want to address this person's symptoms and make him feel comfortable. So again, similarly to a case we discussed earlier, to ensure that he can get the care he needs, in this case, the mental health care. But, I guess the question, is every patient in this scenario equal? I mean, are there circumstances where, we maybe shouldn't, where it might be harmful, or, are there cases where it's pretty clear cut? There's no reason not to give the regular dose. Any guidance on different situations where we might not want to do it, and other cases where it's just 100% safe just to go ahead and do it?
There's just some questions in the chat or comments in the chat, Andy and Isabel, about like connecting with the pharmacy and after hours. And if he's like, this is something I run into because it's that third, my teaching is like, 3 days, and then people are, the dose is reduced, and 140, that's terrible for someone to have their dose reduced. So getting that third day in, but making sure that the pharmacy knows. So when he goes to the pharmacy, he can continue his script, or especially if there's no one in your community who can write him a methadone prescription for the next day and things like that. So I don't know if you want to comment on that, or if anyone in the group, particularly places that don't have sort of next day follow-up clinics, want to comment.
So I think what's really great is everyone's highlighting that they want to help support continuation of OUD, which is the most important thing, right? In terms of being stable, and that's what's going to protect the patient. I think the key thing that people are highlighting is to determine the dose. You need to know how many missed doses they've had before, and Pharmanet's going to be your best bet. Okay, so you're going to review that, and Pharmanet, even if the pharmacy is closed, will be able to be reflective of what they've received in the last few days. And then, as much as you can, as Melissa said, to make sure that if a dose is administered in acute care, you have to let their pharmacy know, because it doesn't show up on Pharmanet. So in order for the prescription not to be canceled and continued, that they have to be notified. Or if it's during daytime hours and the patient might possibly leave, you want to make sure that the pharmacy knows they've already gotten their usual dose so that they don't get a second one. Those are kind of the most important things. And again, if the pharmacy is closed and it's after hours, Pharmanet is going to be reflective of if they've received a dose that day or not. And again, go ahead, Andy.
Oh, I was just saying, what if and then I think we need to get to the nuggets of this case also, and we have one more scenario to discuss. But what if this patient is really sleepy, or if he's just a little bit sleepy? What's sort of too sleepy or not sleepy enough to give it?
So I think what you're trying to say, Andy, is that you want to make sure it's safe to give currently to the patient. So one, you want to make sure that the patient, you're giving it to support them during their stay, or if the pharmacy is closed, you want to confirm the dose by reviewing Pharmanet. And then you want to make sure they're safe to get their dose now. So are they too sleepy now? Are they too sick now? Or is there a possibility you're not sure what their trajectory is? Then it's okay to hold. You've got your immediate release opioids until you can figure out where the patient lands. And you want to be aggressive with those. But if the patient's awake and talking to you, no matter what their recent opioid use might have been, they're safe to get their methadone.
Great. So
I just got a private message just to include in your nuggets about other options, because certainly some departments, especially at night when their pharmacy is closed, don't have access to methadone. And so someone was just asking, what if methadone? And I know even I work in a pretty like an urbanish suburban hospital, and when we have to get liquid methadone from our pharmacy, and it takes hours, and we have like methadone tablets that are either 1 milligram or 5 milligrams. So anyways, I'm just laughing because yeah, it's a lot of tablets for somebody, and we only have a certain amount. So
I think in the end, you have to, obviously you want to support the patient in continuing as much as they can on their opioid agonist therapy, but you also have to consider in every situation, what is the possible harm. In the end, if you don't unfortunately have methadone in your pharmacy, you don't have the capabilities, you have immediate release opioids in your department to temporize and make the patient feel better until you're able to come up with a more sound plan. So perhaps that means, holding in the patient, ideally not. I know we don't want those lengths of stays. We want to hold the patient over till a more concrete plan is done in the morning, or at least so they feel more comfortable to get to their pharmacy to get their dose. Ideally, do you want to give methadone? Yes, but there are other options to make sure you're addressing the patient's need at the particular time while balancing the overall safety. So that's a great question. So to summarize, these are all really great points. And it's just to highlight that it's a bit more difficult to approach this, but the important things is patient selection. So when do you want to give it to the patient? If they have a prolonged ED stay or their pharmacy is closed, otherwise try and support them as much as they can if their pharmacy is open to receive their dose there. It's the safest and promotes continuation of OUD. Address their symptoms with immediate release opioids. If they're they're stable and they're not sedated, give their dose. If they've used opioids recently, that's fine. If they can walk into their pharmacy and they're awake enough, they'll get their dose anyway. And they have much less monitoring outside in the community. How? Review PharmaNet, but know its limitations. So if the pharmacy is open and the dose is dispensed, it doesn't necessarily mean that the dose was given. So you need to call and confirm. Know the amount of days, 0 to 2 days before, missed doses, no changes, give their full dose. 3 days or beyond, they'll likely need a dose reduction. Consider reviewing with a provider who's had experience or reviewing the BCCSU guidelines. And last but not least, safety. The main purpose of this, you want to avoid double dosing or the wrong dose. So always, always, always notify the pharmacy of the dose being dispensed, at least leaving a message. And know how do you dispense methadone, know your hospital protocol. Who do you have to talk to and who do you have to review? And don't be afraid to reach out for help.
And can I just add that, I still think if possible, the best thing you can do is give them if they've been on methadone and they've missed their methadone, and you can give them methadone, to give them the methadone or give them the opiate that they have, that they are used to, because it can be very tricky. Not all opiates or opioids are the same, and they're not necessarily going to be treating the withdrawal in the same way, if you know what I mean. So I would always say, number one, if you can, try to give them the methadone that they're used to.
Thanks, Raya. And that's really just to get the person comfortable and also for that continuation of the OUD and not having a break there. I think those are very important points. I think for the last case, we'll probably go through it, not that it's less important, but we'll go through it a little bit quicker just because we want to just leave a couple minutes for a closing prayer from Elder Fox. So this is a case of a young woman who comes to the emergency department seeking care for opioid use disorder. This is the first time she's ever disclosed to the healthcare system that this is an issue for her. It's also sort of a new and recently disclosed issue to her family. There have been a few overdoses at home. And she also has a forearm cellulitis, and that was another reason she came in today, and she's feeling a bit unwell from that. And she knows about buprenorphine, and she's, sort of remotely think about it, but she's pretty clear that she's not ready to start now, or she's not interested in starting now. So, this is a person who's not sort of necessarily immediately for OUD. Hopefully it'll be in her future at some point when she's ready. So how can we keep this person safe as possible, while she's using and hopefully sort of just continue to support her in whatever way we can until potentially down the road she's ready to start OUD or other treatments. So I know, there's a number of things we can do. And I think probably almost all of you are familiar with take-home naloxone. I think that's something that was mandated on a provincial level, and all emergency departments are doing. And I think everyone on this call is probably very familiar with that. I think, the other thing that is maybe a bit of a new thing that some emergency departments are doing is dispensing safer use supplies. And so, are there any issues around that? Is it something that EDs should be in the business of doing? Are we, I think some people have this concept that maybe that's going to encourage greater degrees of use, or how should we approach this idea of safer use supplies in the ED?
Can I just comment on the notion that it might encourage use? There are folks who will use puddle water to, inject their drugs. So people are going to use their drugs regardless. And so I think it is far better to provide them with the safer use supplies so that they can stay safe and that they can avoid further harms.
Right, I think so much. Yeah, I think that's, I don't think any of us could have said it better. And then can we, Isabel, do you have any words of advice for us how sort of EDs could get ramped up to do this?
Yeah, I think just to highlight some great suggestions in the chat in terms of making sure patients are safer from overdose is talking about the Lifeguard app, making sure that they've got a Narcan kit on discharge. And then to highlight what Raya said is that this is an intervention that actually will reduce harms related to use. So, and will build relationships where patients feel safer in your emergency department because you're meeting where they're at and you're saying, I care about you and I'm worried about you. These are things that will help you be safer when you leave. So please come back. Sophie highlighted that, you can have really low barrier access to safer use supplies. One, if you're not sure how to do it, just contact Towards the Heart. So it's a website run through the BCCSU, and they'll deliver those safer use supplies to your emergency department, not without cost, right? It's covered by the government. And then Sophie said that really one of their DART team had an even lower barrier where the patient doesn't even have to register, that is just in these cupboards that patients can access when they're ready, when they feel that they need it. So that scenario for that patient's like, I know you guys are there for me, but right now I just need to treat myself, and that's what I need right now, and that's okay. This is a supply you can access, low barrier, right? So how do you set your ED up for that? And Melissa, thank you for putting in the chat the website. I don't know if I know, I would really like to hear Raya in terms of those important components for patients to feel safer, because certainly we're coming at it from a very different perspective.
Yeah, and with this case, this person is very reluctant to tell anyone in their life about their use. That's, there's a lot of shame. I can certainly relate to that. I was very secretive about my use and didn't tell anyone. And so I wouldn't even want to take safer use supplies if they were if they were sort of like in the line of sight of the receptionist or the doctor or like, so make sure that they're available maybe in the bathroom or someplace that's private, so that the person can take them on the sly too, because it's kind of incredible the lengths people will go just because they feel, ashamed and they feel that they're not able to disclose or really talk about it, and they don't want to talk about it, and they're not ready. So, try to make them available, in bathrooms and in places that aren't visible to the doctor, the prescriber, who they're trying to impress, maybe, or that. I mean, I'm always that person. I want people to think I'm doing well, and so if they see me taking supplies, then they're gonna say, oh, you're not doing well, or that's what I think, right? So, yeah.
I know we're out of time. I just want to say, like, certainly when I see young people or older people, like, I just want to make people feel safe and welcomed in some way, because this is a 19-year-old who's like is really at risk and we don't know what's happened in her life and the trauma she's gone through, the trauma that she's still going through, and just helping her, you know, create some connections even in her short time in the emergency department is so important. I mean, especially with, well, the young men, but the young women, we don't know if they've been involved in trafficking or anything that's going on in her life, and just being like gentle.
And sometimes being gentle is such a shock to folks, especially folks that have been in the system for a long time, and who maybe have been on, let's say, methadone for 15, 20 years, and they're used to being treated very badly. And so they're not necessarily used to, oh, now this person is being kind to me and gentle to me, what's going on? And so it might take, a few time, some time to develop a rapport, and don't take it personally. It's not about you. You can try your best, you can be your kindest and gentlest, and the person still may not trust you. That's very likely. But maybe you'll get there one day, hopefully, with repetition. If we all do this.
Maybe we can turn it over to you, Isabel, for just some nuggets, and then you can pass the feather back to Elder Doris Fox for the closing prayer, and then we can all stick around if anybody wants to for some additional discussion.
So I think these nuggets is just to highlight the really important points that Raya brought up. So I feel like I'm taking advantage of the great advice that she's given so far. So the important thing is thinking about discharge planning that promotes safety and support that is low barrier and easily accessible to patients. So the things you want to consider is reducing harms of infection. So making sure that safer use supplies are available to a patient, or you know where to refer them to, and that they have means to dispose of them safely. So small containers, reducing the harms of overdose. So you having take-home naloxone kits, knowing of the apps that are available, like the Lifeguard app, or if they don't have a phone, the National Overdose Response Service or hotline, if they have overdose prevention sites or supervised consumption sites, if they prefer to use with other people. So again, some people prefer to use alone, so those apps are important. And then support connection to community. So having a safe space when they leave outside hospital. So knowing what outreach peers or even just clear pathways for referral that's easy and low barrier for patients to access help when they feel ready. Making sure to recognize that, having safer use supplies is low barrier for providers in the ED. Connect with Towards the Heart for delivery of services, or as Melissa said, connect with your regional harm reduction coordinators. And then think beyond the pamphlet on discharge. I know we can be busy, but it can do so much to build those relationships, build that small seed that will continue on further visits, support your patients in accessing those resources, because it can feel very overwhelming. Thanks so much, and I'll pass the feather finally to Elder Doris. Thanks so much.
Thank you, Isabel. Wow, that was really fast, really, really fast hour. It just kind of zipped by, and it's like, but we're not done yet. So, which is good because, I got a lot out of tonight. I hope that everyone else did. The thing that I would like to point out is all people who use drugs or alcohol or whatever addiction need our love. They don't necessarily need understanding at the beginning. They need love and support. So if you're coming from a place of judgment or looking down your nose, my mom used to say, don't look down your nose at somebody else. We don't know their life story. We don't know how they ended up being addicted, being in addiction. Nobody at 2 years old or 3 years old or 6 years old says, I'm going to grow up to be a drug addict. I'm going to grow up to be an alcoholic or whatever. Something happened in their life to put them where they are, choices that they've made, things that happened to them. So if we leave the judgment behind and come from our heart, how would we feel to be treated the way I'm treating them right now? Put yourself in their shoes. There used to be a saying in the 60s, walk a mile in my moccasins. Put yourself in their place and give them, excuse me, all the love that they need. When you do that, they will become more comfortable with you and perhaps, with luck, more trusting, to know that you're telling them the truth, that you're being good and honest with them and treating them with respect. And all it takes is love. So with all that you've learned tonight, and just this last little nugget of information is to give that love. They are fellow human beings.
Oh, it's frozen, Doris.
Who about who town street for them to see. Me?
No, it's frozen. So I don't know if you could get off camera or.
Is that okay? Can you hear me now?
Yeah, it's way better now.
Okay, it's my internet connection. It isn't always fabulous. Sorry about that. But just like I say, come from a place of love, and with all the information that you learned today, we can make this world a better place for each one of us. So I raise my hands in gratitude to you all for coming tonight, and I hope you learned as much as I did. And love to all. Good night. Have a good evening. Bye. Bye, Paula.
Thank you, Elder Doris, for those closing words. For anybody who wants to stay, you are most welcome to. We can address any questions that were not addressed. We just wanted to remind you of a couple things quickly. So there is a 24/7 addiction medicine clinician support line. You can always call for support. There is additional training available if you want it. And our next webinar is November 25th, where we'll go more in depth in terms of the approach to emergency department Suboxone. And I know some people raised questions today about microdosing, and this will be the webinar where we touch on some of those issues. So again, thanks everyone for your participation. And I know Isabel and myself are happy to stick around for a few minutes if anybody has anything else they want to discuss.
Steve Fetter had a question. I don't know if you're still here, Steve, about if people are using fentanyl with methadone. I don't know if you want to address that, Isabel, or I can. I think it's not uncommon. It's not a reason to not give people methadone, but Isabel, if you want to speak to that for a moment.
Yeah, that's so great. And I was trying to highlight that and like, who should we give it to? Essentially a way to frame it is when they're out in the community, while they're getting their dose titrated, where it's not enough and they still need to top up and self-treat with fentanyl, they're still receiving their dose at the pharmacy and there's far less monitoring there. So if they're awake, they're talking to you and you're not otherwise worried in terms of the way they're going to metabolize and take the methadone, they're safe to give the methadone.
Do you have to worry that after you've given it to them, because we have instances where people use it in the department, they use fentanyl in the department, they might go use it after they've been given methadone, and you know, how much is that a true concern, or is that just a theoretical risk?
That's such a great question to answer. And to go back to Raya, what Raya said, the easiest way to kind of address or prevent that is to give them their dose of opioid that they're used to. And again, to highlight that that will often happen in the community as well, right? So it is a possible risk, but the best way to really minimize that risk is ensuring that they're continuing on the therapy that kind of helps stave away those cravings or withdrawal. And the best way is just to let them know and say, hey, I'm giving you this. I just want to make sure that you're safe. So if you need anything more, you know, let me know. We can order those opioids so that you can feel safe and not have to self-treat. In the end, it's allowing the space to say, you know, at times we can't be everything for all patients, but showing that compassion and recognizing where they're at will certainly help build on future visits. Hopefully that answers your question.
Yeah, that's great. Thank you very much.
And can I just, and that was great, Isabel. Can I just add something? I would just add that like many people I know that are on methadone are topping up with street supply. And when I say street supply, I mean fentanyl, but now it's more like fentanyl, benzo analogs, atizolam, all sorts of weird stuff, all jumbled together. So it's not even really. Apparently heroin has made a little bit of a comeback, but it's like mixed in with all this other stuff. So it's not even really just fentanyl anymore that we're dealing with, right? We're dealing with really toxic, poisonous stuff. And the OAT number, like the levels that they're at, a lot of the times aren't sufficient, and they're still finding themselves having to top up. And sometimes they need a different kind of, like a safer supply opioid in addition, right? To help them, like MS-Lon, for example, combining MS-Lon with methadose, or not methadose, Metadol D or methadone, is one way to possibly help them not top up and not need to top up, but it's just, it's very difficult these days, I think, for a lot of people not to, because of the added toxicity.
Yeah, I think to what Raya said, is important to recognize that just as much as you feel like you're struggling to try and address some of the patient's needs, that the patients are struggling themselves. So it's not something you yourself are experiencing, and you know, to approach it with an area of compassion and openness and kind of asking where patients are at and what they need certainly goes a long way. So Raya, I always appreciate your input. It's so great. Thanks.
Yeah, we just wanted to, like, a couple of us will stay on if people want to talk. This is, it's more like how people gather after a talk when we were in person to get a coffee or get a drink. If people had anything to say or any of their, you're welcome to sign out though, but this is, if anybody wants to share something from them or say hi to somebody they recognize on the screen, then you're welcome.
There's a question in the chat, Melissa. I don't know if you want to.
Yeah, well, or you can speak to, I'm just looking, I was just looking up, so I'm just have to catch it up. But if you see it, if you can,
I can
read it out, Andy, that would be great.
So there's a question. There's a question from Elizabeth about screening in the emergency department. What statements, questions would be great to ask? And the comment is, we began asking a triage and quickly stopped because patients had a strong reaction and we had privacy concerns. We then made a sign for each treatment bay stating we are a harm reduction site. Please ask if you're interested to help with any use. Would love some tips.
Where are you from, Elizabeth? Are you still on? Or have you gone? Oh, maybe she's gone.
Campbell
Oh,
River.
Campbell River. Oh my goodness, that's amazing.
I think, you know, it's about the setting. I think we're certainly limited, especially these days in the emergency department where we're just trying to find any space to see patients. So it's, you know, we're not working necessarily with the best environmental constraints. I think the important thing is going back to that philosophy of guiding your patients and openness. I think, again, to highlight what Melissa said, like, creating that space initially with what you can to say, hey, like, we're open to talk about this. This is a welcoming and safe space, as we do with a lot of other kind of perhaps more marginalized, not marginalized populations, sorry, that's not the right term, but for other populations who might not feel safe with the stigmatization that they feel sometimes in the emergency department. So that's great. The other part is to just ask for permission and to say, hey, I'd like to ask you these questions, but to be clear, to clearly state why. So I often say, I'll ask a lot of patients whether they use substances, so I can make sure that I address any withdrawal that might make you feel uncomfortable during your stay. Is that okay? And then that's really clear that I'm not just asking to pry, but because I'm asking from a place of compassion and that I want to treat everything that they're here for. But honestly, it's just being really transparent is the important thing. And I don't know if Raya or Melissa or Andy have really great advice to give. I certainly have learned from them as well in terms of great ways to approach patients.
I just want to say thanks to Elizabeth for just bringing up that issue of sort of the triage screening questions, which I think is so tough. And, you know, now triage staff has to ask all kinds of COVID screening, and there's just a million things going on at triage. And I think it's awkward, can be awkward both for triage staff, you know, and for the patient to have, you know, when two people have just met 30 seconds ago to go sort of directly into drug use. And that's, you know, the triage is not only is it the person's first couple minutes in the emergency department, it's also a very sort of public, noisy area. So I think the approach with the signs is it's sort of recognizing that triage is so suboptimal and trying to find opportunities elsewhere with signs. You know, they could be in triage just to get people thinking. They could be in all the bays and washrooms. I think that's great as a way to get people talking, and then I guess, or thinking about talking or sharing where they're at with substances. And I'll typically often not only say I'll occasionally say what Isabel said about asking because I want to address withdrawal, but I'll also say, hey, there's sometimes, you know, I ask about substance use because sometimes there's certain diseases or complications that are associated with that. And I'm sure I want to make sure we don't miss anything. So that's why I ask all my patients about, you know, about the substance use. So I, you know, I know what people are at risk for. That's another way I kind of lead into it.
Yeah. Yeah, I agree with Andy. I think transparency is, I mean, the more that you can explain what you're doing, because really it's you know, it's the patient's care, right? And so they have a right to know what is going on and what's happening. And a lot of the time, patients and I have even experienced not being given a lot of information about what's going on, right? And feeling almost like if I ask a question, I'm bothering someone, right? So the more that you can get ahead of that and explain, like, yeah, this is why we ask these questions. I know it's kind of awkward. You know, we kind of have to ask these COVID screening questions. I know you've probably heard them a million times, and try to, you know, be a little bit casual, friendly, and certainly explaining what you're doing and why you're doing it, and giving them a chance to ask questions as well.
Anything from anyone else who's still here about, I don't know, things that have worked in their departments or? Cam? I'm just going to call people out to see if they're even still there. Do you have any comments?
I think some people are signing off.
Yeah.
I
Joanne,
think
you guys can sign off. I'll wait until 7.
I think the other thing comment somebody made earlier, which I think just brings us back to this, is just how, you know, I think the idea of there's sort of almost a self-serve harm reduction supplies, or letting people know that it's there and they can grab it, so people don't have to necessarily openly disclose or ask for it if they don't want to. I think that's a great idea also, and I'm sure there's some logistics around there, and making sure, you know, one person maybe doesn't take, you know, 300 supply kits, but you know, I think that's also great, you know, just to put the person in full control of what they want to disclose, and getting supplies if they want them.
I just want struggling, you know, kind of respect, I think, goes away to get into what is really ours. Yeah, so
If you turn your video off and just speak it sometimes, you want to try that if your connection is less? We don't know your name because you're marked as Nicole, but.
Well, Cam, you can hear. One of the things is, especially the conversation, really nice, you know, engagement and you, you know, buy it, build relationships with people who are. So I think nice. I'm not sure if you can hear me with this. It's a nice.
Maybe if you can hear us, we had really trouble understanding your comment. I don't know if you want to put it in the chat, and then we can read it out. Just because it was hard to understand.
Charles has a question about objective cows. If there's a score you can use for objective cows. I just want to say before you answer, Charles, so I work at Burnaby. We never had addiction doctors at our hospital. Yeah, it was until like this July they came, and it's been amazing because, like, I don't know, it's just amazing. But they'll like write objective cows scores or objective CWA scores. I don't think it's validated, but once in a while they do, and the nurses like love it because it's just clear. But anyways, go ahead, Isabel, sorry.
No, it's okay. Yeah, and certainly I think it just highlights that there's a limitation to any withdrawal scale, so you just don't want to set it and forget it, right? It's supposed to guide you. There is no, unfortunately, validated objective cow scale. What I was trying to express is that you just want to look at the overall score, and you want more of the things that you can see. So I see piloerection, I see diaphoresis, I see dilated pupils, I see the person is like rubbing their legs and pacing. Is contributing more than the subjective symptoms. And again, it's not to disregard the importance of asking the patient how they're feeling, but that just provides you more of a buffer and a clear kind of sense that yes, the person is ready to start Suboxone. Because oftentimes they'll have, and you'll feel this too, it's like, I just want to get started. This is so painful. Why do I have to wait for so long? So you want to make sure that you're giving them something that's going to make them feel better. So again, you want to look overall at your score, how many of the things that I observe are more objective, and you want a larger proportion of those contributing to your total COW score. But if anyone wants to do a research project, that could be a great thing to look at for sure.
I know when I work in Fraser, and we were doing a few years ago, when fentanyl wasn't as much a concern in our region, when we were doing our take-home patient education sheet, like giving an option to the sows, we do like, you need 3 or 4 of these things. We purposely just picked the objective ones from cows and sows. So we didn't include, we picked like goosebumps and anyways, yeah, for that reason. Where do you work, Charles? I think you'd said.
Hey, sorry, juggling kids here. So I work at Surrey and Lionsgate. Surrey's got a great new addictions nurse. Fantastic. And they really autopilot stuff for us. So that's good. Lionsgate doesn't quite have that, smaller shop. And I'm trying to reduce my barrier to getting stuff going for patients, right? I feel that obviously that's why I'm here, to get more of a knowledge there. So I want to know confidently when to pull my trigger on the cows and when I can start my Suboxone dosing. So it was very helpful, the pearls. I'm wondering, for most patients, they're not in intense withdrawal, but I established they've got a bad opiate use disorder, and I want to help them. I want to help them now. So I'm also curious about microdosing or starts to buprenorphine without putting them into withdrawal. I'm assuming this is something for another day. This is the 101. Yeah. Anyway, so I'm asking these questions, trying to reduce my barrier to getting someone started for the patients I usually see.
Yeah, that'll be, first of all, thanks for participating and looking for ways to kind of improve care for your patients. It's so fantastic. Yes, so we have a future webinar on November 25th that will be dedicated to all the different ways we start Suboxone outside of the standard induction, and a large proportion. And a loud and clear question we've had is around microinductions. Without going in the nitty gritty of it, I would say a larger proportion of my starts certainly are microinductions, but to have a good understanding of what that means and how to approach it takes a little bit more finer details. So certainly we'll be going over those pearls, and I hope to see you on November 25th.
And it's something in Surrey, Charles. I know David, for Fraser, my main contacts at your site are, Craig, and then David King, and then Sally. I help coordinate the overdose response for Fraser. But I know David had asked me about microdosing and maybe should we start that regionally? It's not really supported, having the packs regionally. This is just a Fraser talk now, but because our regional addiction it's sort of off labels, but I think at the Surrey, there's a potential if your site wanted to do a test more, to help the emerge docs do it or test it and then connect to Creekside. I could help support your site doing that. It just sort of depends, right? Or people do it individually, or anyways. You'll learn more, and I can talk to David and Sally and stuff about it too. And
I think Dave's a great contact there to have one voice kind of speaking to the group about it, but I'm sure there'd be interest.
Yeah, Surrey's been a bit of a funny state just because there's so many docs there, and there's there's a lot of resources too with the addiction assessment nurse there and stuff. So, and with Creekside, the RAC clinic right across the street, and a lot of the docs have not been as interested in getting involved because there's so many other people to do it, right? So it's hit and miss, but there's definitely a few really great advocates there for sure.
And Charles, just one more thing. I think just coming down the pike for Lionsgate, I think we have as sort of a new regional lead role. So I'm trying to support Bridget Cassidy and others at Lionsgate to sort of get more services started. And I think it's still a ways off, but I think, way down the road, hopefully not that far down the road, but we can come up with a regional approach to things like microdosing, where it's not every practitioner or every ED has to sort of figure it out again, but that there's sort of a regional standard or even microdosing packs. There's a study on that at BGH right now that will also start at St. Paul's later on this year. So hopefully all this will kind of move us to having more options on a regional level where, and it's sort of pre-packaged solutions, just in a way that a take-home naloxone kit is a sort of a pre-packaged solution. You don't have to kind of figure out how to make one, on the spur of the moment. So I think we're all hoping to move more in that direction and reduce barriers to providers and for patients.
Yeah, so come to November 25th.
Yes, definitely. I think
within microdosing, something I could see at Surrey is not maybe, because there are community resources, right? People can connect, and there's a bunch of outreach, and they're starting these overdose outreach teams and more like intensive management teams that'll connect with people in the community. It's not like doing a whole week, but doing VIHA at a couple sites is doing more, just giving like 0.5 milligrams twice a day for a couple days or something like that, giving them like the first couple doses and then connecting them to a community, right? Like splitting the 2 milligram in 4 and maybe just giving them that for a couple days and telling them to take it once or twice a day. Isabel's more the expert on that, but I could see that maybe working in Surrey a bit more because it's easier for people to connect in the community, I think, than some other areas.
That's a great teaser, I think, for you know, our next webinar, and maybe I'm seeing it's 7, and we can.
Yeah, we can shut down now.
Okay.
Thank you, everybody.
Hey,
Thanks so much.
Nice to meet you. Thanks for coming. Thanks, Melissa, for all your help. You're great.
Oh, no, thank you. It's great. I loved your slides and.
Yeah, it was like pulling teeth sometimes. Whatever. You did such great engagement. So happy that you were there. So like, you know,
With the audience, or?
Yeah, I think it's just like, I think that's just part of engagement. So it sounds like at least people got.
People take a while to get warmed up, and it's harder. It's a big group and stuff, but no, it was great. You guys were so clear, but it'll be good with the longer ones. I think you can create more conversation and stuff too, but those were, yeah, I loved your slides. Well, I guess I'll see them when they're posted.
Yeah, if you just want them, I'll send you a copy.
Oh yeah, send me a copy too, just so I can go through them, because I was like following the chat more than your slides to make sure I wasn't missing things. That would be great. That'll be great.
I'll send it to you. Add it to my million to-do list.
Yeah, we'll see how the next one goes.
Yeah.
Hopefully, do you know what's good? Who's leading that one? Like,
oh, pardon my French. Now it's recorded.
Sorry,
so
you want to go in on, but
no. This is like nice. I've like decided I'm not going to do anything the rest of the night. So we have Jody. I think, you know, the problem with VIHA is that they're just so strapped. So I think it'll be like a VIHA invitation with us filling in is what I'm getting.
Because I don't think Jody would be like me, well, even probably less than me doing it. Like, I'm not gonna, like, I don't have enough experience to speak about all the different things because I don't see people in follow-up. I don't know what happens, right? Like, unless Ken wanted to do it, but I think having you or someone do it, and then having Jody just show up and give her, this worked, this didn't work.
And that's the intent. It's like to say like, oh, this is the addiction provider with all this experience telling me what to do. Well, that's not feasible. They don't know what it's like to work in a center. So that's why we want both experiences. And that's where I think I wanted Anne. But in my conversations with her, she was essentially like, I am strapped. Like, I'm strapped until maybe like the end of March. I have confirmation with Interior. So they'll be for one of the last 2 panels. So that's great.
And Fraser, I'll sort out with Sharon. Like, I'm in conversation with Sharon and John.
It's going to be great. I'm not worried about
and they just haven't picked an
addiction.
They haven't picked an addiction person.
Yeah.
I'm not sure what's going on there, but whatever. They're just busy. But John, I've just done a couple, like a PSLS, which is related to that for like a regional, they do these commission. So he would be a good one, or Tara, we'll see. It'll come together. There's a little bit of a dance, just there's a bit of background with involving people, because like when I involve addictions and the harm reduction, people sort of get offended that because it's like addictions isn't harm, like, because like they're the experts in harm reduction. So why are you asking an addiction doc? But then the harm reduction people, I have to be, sorry, you don't want to hear, I have like so much baggage about everything.
No,
it's amazing. But there's one of them that I don't want to come because like she came to because she can be really abrasive and more like, so I don't want to do an open invite because I think they'll pick, if they pick her to come, then it won't we don't want her there. Like the emerge staff didn't connect with her well.
Yeah.
Because it
I
was
think
too much, you know, it was like, it was too much for the emerge staff. So I'm just working about a little bit about like the politics and the dancing around, like not offending people, also like maintaining my relationships with people.
Yeah, that reaction you saw is more so like, I feel like 3/4 of this webinar series is doing that. So it's more so like, oh, can't just ever be about the content, you know, it's about making sure
So
you
not
appease everybody.
about that. Always. It's about like, and the other thing, so Doris did well, like, because
oh, perfect.
Not that she did well, but sometimes it can also be like you offend people because like they're like, why are you having me there if I'm only have 2 minutes? Anyways, it's all just like,
yeah,
it's
we
a
thought we
dance.
offended her. Yeah, that's what I mean, where it's just like a lot of the dance. So my reaction wasn't to what you were saying, it's more so a reaction to yes, I felt that as well. So a lot of it is just trying to make sure to appease all the stakeholders, as you said.
But yeah, hopefully people will come to the next one. I think they will. It was interesting, like there were about 100 people registered for this one.
Yeah. I think this 5:30 slot, because I had a couple people be like, hey, it's kind of a bad time because of kids. And I was like, oh yeah, like 5:30 is, that's the only thing with the 5:30. I think no matter what we do, the morning, it's like people are in clinic, midday, people are in clinic or doing other things, so they can't join. End of day, the kiddos. So that was the only thing.
You can do it like from 7 to 8, like later. That would be the other option, but then it's late, like, I don't know.
I think Nicole explicitly said, like they explicitly said from the BCCSU that they can't do anything later that finishes later than 6:30.
Yeah, it's hard. It's hard to pick the time for sure, I think. 5 to 6, but still it's the kids, it's hard because it's right around dinner and after school. And
yeah, that's the only thing where we might lose a lot of people. So I mean, the other thing too, we'll just, if this is a popular webinar, like there's a lot of registration but people don't show up, then we can always redo it. I was thinking, I wrote like doing a summary PDF also for the webinar so people can read it. Yeah, because even me, I was like, am I going to watch an hour-long video? I have to be in the right mindset. So another way to access it would be just like a summary. So yeah, I've wrote little nuggets.
Yeah, this one would be very transferable to a set, like you essentially have it done.
Yeah,
this would be a great PDF.
Yeah. So
yeah, I'm curious about the buprenorphine naloxone one. Because it's like, I don't know what to do anymore. I'm so confused about when to start people. Like I used to be like a few years ago, it was like, yeah, here, just take time. Like, oh, how long do you wait? And I don't know what you guys are doing. I guess more micro inductions, right?
Yeah, unless they're like showing, I honestly, my approach is, and I think that's what I want to highlight, is like in the end, if you can carry the patient to a standard induction, that's what you want to do, because it's going to be the shortest time frame to get them on buprenorphine. But in terms of practicalities, I generally have only started people on a standard induction if they've waited already 2 days, like they're showing up to me in withdrawal and it's been 2 days. And honestly, at that point, I'm just giving them 16 milligrams. I'm just flooding it because already at that point, I'm like, oh, you've already kind of gone through the worst of it. Most of the time they're like, I've already gone through the worst withdrawal and I'm coming down. So I just get them to right dose quickly. I don't kind of mess around with it.
That's a better approach. Well, I don't know. It's sort of like Sharon, when I've talked to her about what, like I'm like, what do you want us to do? She might have changed. This was a few months ago. She's not super into the micro inductions, or she hasn't been. And I understand her point because it's off label. It's harder to promote things as a leader when it's off label. You're not really supposed to. But she's more into like transitioning people onto hydro. She says that this is what she was doing just in our conversation, like giving people hydromorphone for a few days and then doing a traditional induction from that, which is sort of out of the scope for the emerge docs, I think. Like,
yeah, and even then it's, you know, so for example, whenever I've done that, it's when the person has adamantly refused all OUD, and they're like, I just want hydromorph. So I say, okay, but then we're going to have this conversation in a week's time about starting you on something, because this is not therapy. Like, this is not going to protect you necessarily. I'm not going to replace your withdrawal. And I think the biggest thing for you is like, that's a conversation that's certainly out of the scope. And I think as an emerge doc, in my role as an emerge doc, I don't start people on safe supply because I can't sit down and have that nuanced conversation. So I think that's where microinductions, I think we just recognize that in a lot of stuff in the ED we do that's like off label, like looking at alternative uses of ketamine. I think it just meets people's needs where they're at. I think the educational material for patients will just need to be really, really robust so that it can be offloaded from the emerge docs. You know, that's the only that's my biggest kind of, not concern, but certainly something that I think needs to be addressed.
Yeah. Yeah, it's so interesting with that fentanyl. Who would have thought, but that would happen.
I remember some of my first inductions when I started as staff, and I was like, what the hell is happening? Like, people who were waiting 16, 18 hours in bad withdrawal, and I was still precipitating them. But, you know, when you just think of the pharmacology and how lipophilic it is, and if you think of the equivalent of like cannabis, it's just because you're taking so much, you're delaying the onset of sufficient withdrawal. But then the withdrawal onset, which is tricky, is actually still 6 hours. So it's a tricky beast.
I had one young man come in. When was this? Like, it was that night, so you guys weren't involved. Like, the addictions wasn't involved. I don't know, a couple months ago, or he actually followed up, who had just been using he was young, he was like 19, but he was only using hydromorphone, right? He had used to use something else, and now he was using hydromorphone tabs and just like snorting it or chewing them. Like, still had like opioid use disorder, but not like, I mean, it's obviously still, it's like now I'm like, oh, hydromorphone, it's not even severe.
It's so funny, that perspective that changes, right?
But it's actually like he had enough time, like, and he was interested, and like, so I gave him like a take-home pack because he wasn't in enough withdrawal. And then I followed up with him. Like, I called him. I usually call people the next day if he had a phone, like he was living with his mom and stuff. And then he actually did follow up with the rat clinic at RCH, which a lot of people don't. Yeah. Anyways, but it was so high. It was so much easier because he was just on. He actually gave us a urine too, which most people won't like. But then there was no fentanyl in his urine. It was just opiates. It was like so much easier to do like unobserved induction with him, because it was like, and for him, it went like, he's like, oh yeah, I'll just wait. It was like, no problem. I'm like, oh, this is probably how it was when they did all the buprenorphine studies, right?
Yeah, when it was just heroin or hydromorph. Yeah, I've seen a couple of those cases. Certainly it's like younger people who are getting just into hydromorph use disorder. But it just highlights that we really, you know, everything, I think, full disclosure, and there's just not enough time in this format, is that everything we know about fentanyl is like we're assuming and extrapolating based on like doses that are so minute compared to what people are using. So, you know, we just have to innovate based on that. But yeah, for standard inductions, either they're using hydromorphone, I confirm on UDS, it's just hydromorphone, or most of the time I'm having to wait. They're self-presenting 2 days later, and I'm just doing the standard induction in those contexts. So.
Yeah, no, I think it'll be a good conversation. I think it'll be useful for people to hear, because I think like, yeah, like Mornay, he put up, Mornay's the local department head in Chilliwack, actually. I'm impressed he came. He was pretty good. Not pretty good, but he's like way more interested than he was a couple years ago.
Yeah.
But that's what he said, that it, like he was probably like, people get sick after 12 hours, or that was his experience, which is true now, right? Like,
yeah. They still get sick at that early time, but they're not sick enough that you're not going to make them sicker, which is the tricky.
Oh, but when he's given, like, I think he had a comment in the chat, then when he's given Suboxone after 12 hours, even if someone was in withdrawal, his experience is worse. Yeah. So he's a little.
Yeah. Hesitant.
Anyways, we'll see. Hopefully we'll get attended. I think people will come for the next time. Hopefully.
Yeah. Yeah, and I think, you know, we'll just if we think the time is just really a barrier, then we might just have to reevaluate for the next webinars. And if not, then
I mean,
morning
is hard because people are getting their kids to school.
Yeah.
Lunch hour, like I'm just cognizant that outside of the urban centers, a lot of the emerged, not a lot, but a percentage of the emerged docs will still occasionally do clinics. So like
yeah, exactly.
around the people's clinic days, lunchtime. I don't know. It's a bit too much.
There's no right time, essentially.
Time. Okay, yeah, we'll have a conversation. Okay, you sign off first so I can close the whole thing down.
Yeah, I'm gonna send a doodle poll. We're gonna do like a post content debrief sometime in the next like week or so that we can hit the ground running for the next one. So we'll see you then. Thank you so much for your help. It was great.
Thanks so much.
Bye.